the TASA Group, and we will be starting our presentation promptly at 2 o'clock. Mary Falbo is here online waiting to begin her presentation. So again, I want to thank everyone for joining us, and again, we will start promptly at 2 o'clock. Good afternoon, everyone, and thank you for joining us today for our presentation, Common High-Risk Coding and Compliance Areas, and How to Mitigate Your Client's Risk. I'd like to welcome everyone today and again to thank Mary Falbo for her presentation and being with us today. But before we begin, I would like to take a few moments to review and highlight some of the necessary CLE tracking requirements, as well as some of the updated information from WebEx. Please remember that if you are applying for CLE credit, you must log onto your computer as yourself. As a provider, we are required to have supportive information that you have attended. If you are logging on through an iPad, you must also, you won't be able to log into when I ask you to enter the coding. So if you want to apply for CLE credit and you're using an iPad, you have to go in through the teleconference and then email me the password, which will be coding for today. And when you do that, I also ask that you enter the time that you're entering it, because as a provider, again, we have to be able to have supportive information. Today, Ms. Falbo will, from a legal perspective, cover the common high-risk coding and compliance areas that attorneys need to know to help their clients mitigate risk in the medical coding areas. The session will address the following issues: the common high-risk coding and compliance areas within their specialty, understanding some of the ongoing areas of investigation by the Office of the Inspector General, Medicare, and third-party payers, and learning key steps that attorneys' clients can take to mitigate repetitive common coding and compliance errors. Our presenter today is Mary Falbo. Ms. Falbo holds a Master's of Business Administration from LaSalle University and received her Certified Professional Coder, or CPC, certificate from the American Academy of Professional Coders in 1998. Ms. Falbo is the president of Millennium Healthcare Consulting, Incorporated, providing services to healthcare providers regarding managing the business side of medicine. In addition to offering chart audit reviews to ensure CMS documentation compliance, Millennium conducts educational sessions on evaluation and management coding, Medicare regulations, billing updates, and other coding topics. Ms. Falbo is a member of the Pennsylvania Medical Group Management Association, American Academy of Professional Codes, and AHIMA, an editorial advisory board for the Coding Institute's publications of Internal Medicine and Family Coding Alerts, OBGYN Coding Alert, Orthopedic Coding Alert, and other various specialties. She is the technical editor for Decision Health's Internal Medicine Coding newsletter. Mary welcomes your questions today. So when you want to submit a question, please use our chat feature, and that's located to the right side of your screen. And you can submit your questions throughout the presentation, as we will take intermittent breaks so that Mary can respond. Then tomorrow morning, we will send out an email with a link to an archived recording of the webinar. Also today, before leaving the presentation, we ask that you do take the time to complete the survey that will appear on your screen after today's program. The survey is also a CLE requirement in some states. For CLE requirements, those of our attendees who require a code word for tracking purposes, the code word for today is coding. During the presentation, we will take short breaks, and during that time, we will ask that you enter this code into the chat feature for CLE reporting purposes. And that chat feature is the same where you would submit any questions for Mary to answer. At this time, I want to thank all of you for attending, and especially Mary Falbo, who is our presenter. And now, Mary, I'm going to turn the presentation over to you to begin the presentation.
Thank you, Carol. Thank you, everyone, for joining. And I hope in the next hour that I will be able to provide some insight or additional information or validation or confirmation on how attorneys can work with coders such as myself and companies of such as myself so that we can be the strategic alliance to your healthcare clients. And most often, most often what we hear from our practices is, why should we be concerned with compliance? Oh, we don't have the money, malpractice is difficult. Here's the reality, and these are some numbers, and we appeal to you as attorneys. When I work, I'm fortunate enough that with all the attorneys that I work with, they have a great understanding of coding in terms of what are the key issues. Not that you are the technical expertise, just like we're not attorneys, but together we can help a client say, hey, let's come up with some pragmatic solution, because to do nothing in today's day and age is not the answer. So usually when you meet with your clients, whether it's once a year at your annual board of directors meeting or physician meeting, I'm hoping, as I know when I talk to some of my other attorneys that I work with, that there's always an update that says, here's the current climate on the DC front, and this is what Medicare is also doing. Right now, based on the latest data, the OIG reported $6.9 billion in expected recovery for 2012. And there's the link that talks about it. The 2013 hasn't been summarized yet. And in 2012, these RAC audits, the Medicare recovery audits, exceeded $2 billion. And then part of the ongoing local Medicare fiscal intermediaries within each state, they call it the CERT, which is just random probing or the comprehensive error rate testing. The CERT program noted improper payment rate was 8.5%, which represented $29.6 billion in improper payments, and there's the link that supports that. On the private payer side, companies such as Equiclaim reviews the coding profiles now. We've been very busy with a lot of the private payers. And some practices say, well, my practice is we have a small bit with Medicare. It's not just Medicare, it's the third-party payers. If you're a pediatrician or primarily third-party payer, in our market here, the blues products are very prevalent. It's really important we say compliance is a culture. It's doing the right thing. It is ethical business practice regardless of the payer. It's a culture. And now every state Medicaid program has an integrity program. So, in sharing these numbers, you can see, why should I even pay attention to it? So that is really important as to why they should be concerned with it. Moving on to the next slide, okay, the OIG, and by the way, they just released the 2014 work plan in January. So today, and it just reaffirms what I'm going to talk to you today on the 2013 about areas of coding risks. So the pattern is the same, because as you can see, with these huge recoveries, this is not going to stop. And what I say to all the attorneys is just this. As you meet, part of whatever your role is, whether you work with an entity that has an in-house general counsel or you're working with these large practices, one of the requirements, as some of you may know, in the new sentencing guidelines, basically says that, hey, in order for the compliance program to be effective, there has to be some sort of prudent corporate governance program in place where the responsibility of these high-level personnel has substantial control, and there is this periodic reporting to the board on the status of the compliance program and the resources required to maintain its vitality and the organization's response. So that's where I'm going to appeal to you that we work together on ensuring that these entities establish this corporate overall compliance program. I'm going to talk about the specifics of the coding aspect of it, but again, my appeal to all of you is that you as attorneys to your clients are the ones that engage us under attorney-client. You're the ones that the doctors, the healthcare entities listen to more so than us. We are your strategic partner. We come with the technical skill. There are times we actually recommend attorney-client, and then I will call an attorney. So as I go through these slides, please keep in mind that I'm hoping that you share this data with your clients during your annual Board of Directors shareholders meeting or quarterly meetings so they understand the impact, and I'm going to come up with some pragmatic solution so that you understand where the coding vulnerabilities are, so that hopefully you can say to them, well, listen, it's not a comprehensive A to Z document. Let's start. It just has to be effective. Let's just do like an external audit. Let's just focus in on these key vulnerable areas. And that's where I'm going to go through so that you as attorneys know what these vulnerable areas are so that you can come off intelligible in terms of the coding risk areas and represent us. So the OIG between 2001 and 10 for the Medicare Part B, which is the professional side, the services increased by 43%. And so during this time, the evaluation and management services, these are the visits that the doctors do. This is not taking into consideration procedures, surgeries, et cetera. This is just pure visits to the doctors, okay, regardless of specialty, increased by 48% or $22.7 billion to $33.5. And what they noticed is that from 2001 to 10, physicians increased their billings to higher level evaluation and management codes. We talk to them as the higher level codes, the moderate high complexity codes, and I'm not going to confuse you with the numeric. And these evaluation and management services have been vulnerable to fraud and abuse. And primarily, we find that it's not that the complexity of the case didn't support it, but the documentation requirements, it's low-hanging fruit stuff. It's the history and the exam. And this coding trend, here's the report from the OIG if you want to show that to your client. So what I said earlier, if you had to pick one area, whether you're representing multiple specialties, ask them to just start with their evaluation and management services. Start somewhere. If they can't do all aspects of their services, diagnostic studies, imaging, etc. And the evaluation and management services have also become an important scrutiny in light of in light of the electronic medical record. So on slide 10, and this was an interesting evolution. Of course, the practices are incentivized by Medicare to convert to electronic medical records. They do so, and as I mentioned in the slide before, evaluation and management is the key high vulnerable area. And sure enough, on the 2014, they said the same thing. We're going to look at evaluation and management. So if you want to take a rifle approach, just look at the evaluation and management, and we say focus in on the higher levels of services. But as some of you, as you may recall, okay, on September 24th, when the U.S. Attorney General Eric Holder and HHS Secretary Kathleen Sebelius sent a strong word saying to hospitals, knowing that any attempt to game the system by using EHRs to boost payment to code a higher level of evaluation and management service would not be tolerated. And this letter was sent 2 days after the New York Times article linked the electronic health records with a rise in Medicare costs. And then in the late September, CMS approved these approved recovery audit contractors, RAC audits, to look at E&Ms. So at first it had many physicians alarmed. And so what happened there on the next slide, okay, is that most practices said, wow, we see this letter, we see it in the 2012 work plan, we saw this continued in the 2013 work plan, and now just the other day, and your presentation was already turned in, we're seeing the same repetitive verbiage in the work plan, in the OIG work plan for 2014. And what they said they would do, okay, is they're looking at the frequency of medical records with identical documentation across all services. Well, a lot of the doctors will say, well, we're doing templates. Part of our clinical style is to have some level of repetitive, head-to-toe, multi-system review. But what's really important is we say to the doctors, listen, the electronic medical record is supposed to mirror what you did on paper. It's just now legible. And now the phrase out there, the mantra out there is just because it's legible doesn't mean it's intelligible. And what we see as auditors, we see a female coming in for a prostate exam. Okay, so there's like inconsistencies between what the doctor points and clicks that doesn't even apply to the female anatomy and vice versa. And, the question is, if they're coming in with a sinus infection, do you really need to do a comprehensive exam? Hey, if they're a teaching institution, maybe. So, again, what they mean here is it's just, it has to be clinically relevant. So there's a lot of education that has to be brought. But the point is, again, it just reiterates that this is a very key high area. And I apologize because I'm not navigating this. So anyhow, on the next slide, okay, while Attorney General or Holder, the announcement went out, a lot of the physician groups and a lot of the hospitals, and I work with a lot of the physicians too. I really do believe that the majority of the physicians are trying to do the right thing. They're trying to navigate medicine and do the right thing. And I think that the electronic health records have helped physicians more accurately document and bill for their services because they had the complexity of case and they, had to miss like a minor technicality in the history. So I think there's a big difference between upcoding for the sake of reimbursement, which is fraudulent, as you all know, and taking advantage of tools that legitimately make billing for the equitable payment more efficient. So while the government is investigating the potential of EHR because of their increased payment, we argue, and as some of the physicians in the healthcare industry have argued, is that it's because in the past they just left that money on the table, and the EHRs allow the physicians to better document and more accurately bill for their services. But nonetheless, because we have this particular service high on the radar screen, let's not let the legitimacy of using the EHR be overshadowed because they have cloned similar notes for all patients, for all conditions, and they're abusing the use of the EHR, be it unintentionally. So that's where somebody says, well, I look at all my coding, we have a peer-to-peer. There's still that level of, are you really using that electronic health record appropriately in terms of these potential risks on clone notes or relevancy? Are you reviewing it to ensure that there aren't anatomical anomalies and inconsistencies and errors along there? So moving on to the next slide, and again, I apologize. I think what's happening here, the slide is out of sequence with mine. So I apologize for this. Let me get to the next slide. Okay. Yeah. I think there's a slide missing here, so I apologize. Yeah, that's what it is. So then, so moving on to the high risk areas, the other particular area that the OIG is looking at, if you're working with your surgical practices, are these modifiers, and we all hear of the modifier 25 and 59. So if you want to summarize to your doctors, they're looking at evaluation and management, They're looking for services that you bill with a modifier 25 and a 59. 25 says, hey, the doctor did a visit and an office procedure the same day. 59 is for surgeons, be it an orthopedic surgeon who's doing multiple procedures, and 59 allows them to legitimately unbundle and get paid for both procedure codes. So these are the surgical areas, and I say to the practices, and this is where if you had to advise your client, say, hey, let's do a risk-based approach. If you need to do some level of auditing, you recommend it under attorney-client, key in on the high-risk areas, because that's what Medicare and the payers are doing. Look at your high levels of evaluation and management. Let's do a focused probe review on that. And if you have the time to do the additional sampling on the office visits in E&M with the 25 or the surgical services with 59, then do so. The other big area that as attorneys, and some of you may already be involved in it, is the use of these advanced practitioners. There's still that gray matter where not only do they not understand the guidelines of billing incident 2, which says, hey, I'm a nurse practitioner, I did the service, I'm billing under the doctor, and I get 100%, or is it, according to the guidelines, should I be billed under my own, tax, my own provider number and get 85%? But where attorneys get involved, and we work with attorneys and help them understand if there's a violation in the use of these advanced practitioners in compliance with Incident 2 and shared split, I think what we find is a lot of the practices fail to take into consideration state law requirements. And, attorneys help research it, we research it together, and there's some supervisory requirements for each individual state. So in dealing with these advanced practitioners, it's not just these billing regulations on the federal level and whether the payers follow Medicare guidelines or not, is now you have to say, well, I got to take into consideration state, the state law. So that is something that, is really important to take into consideration. Then to get back to the EMR, here are the issues from a legal perspective. And this is something that I'm sure most of you have already dealt with, but there are some potential authorship issues, with some EMRs, it's possible for one clinician's entry to appear as another clinician's entry because the first clinician did not sign off the record, So then the question that comes in, when this happens and the patient suffers an injury, both clinicians will want authorship of the medical record to be correct when the entry is printed for litigation defense purposes. The other more fundamental issue is while it's wonderful to have these electronic health records, there are legitimate ways to make the addendum corrections, late entries to that. They're using them as word processors. And so the question becomes, have they compromised the validity of this document withstanding the definition of a legal document? Are you backspacing, erasing? So, of course, AHIMA, the American Health Information Management Association, has issued clear guidelines. So, that's one of the things that the compliance officers, the board of directors, the top organization policy, they need to have a health system universal policy on this is how we make addendums. This is how we handle late entries. This is how we handle two-tiered passwords. So these are things that they should review these policies, with the electronic health record with you as attorney, because only you guys, I can't answer, do you feel that if they, does it have an audit trail? Will it withstand the acid test of being validated as a legal document in the event of a malpractice, a probe review, anything, a litigation case. So that's the important area that that most of the doctors don't realize that simple use of it as a word processing, compromises things that a manual record wasn't an issue. The confidentiality, okay, it's amazing how, just a basic HIPAA violation, we'll see nurses, MAs, another doctor's nurse, all these people accessing this patient encounter. And I think that there should be safeguards on which, to make sure that those individuals have a legitimate reason to access that medical record. It's just, that's an area that we see multiple entries in there without appropriate authorship on top of it. So you say, well, how do you know? How can you tell when it's typed? When we do an audit, well, there is, what we see is a bunch of different signatures down the bottom, even though we don't know who did what. So we're like, well, why are all these people involved? And then there are times when we go to a question and we ask for supporting documentation to say, give me the audit trail and who took the history. So we go in and we audit and we can, and the good news is that a lot of our clients do have a great EMR that is certified that has that audit trail. So if we're doing it, you know that if there's a question or there's a complaint or a whistleblower or any type of issue, that that audit trail will unveil the discrepancy. And then there's, I talked to you about it, all of you earlier, about the integrity of the patient encounter. Okay, without these appropriate guidelines for addendums, corrections, deletions, all these late entries. Okay, is it capable of withstanding a legal review? If the information needs to be added or comments made after the entry is locked, a new entry should be written and clearly identified as an addendum with the current date. So these are guidelines that AHIMA mentioned. But you know what? Based on each state regulations, we always say, hey, these are HEMA's guidelines from a coding compliance, but you need to check with your attorney to see if it will stand the laws within your given state and if there's something else that we're missing. And most often, after I write my executive summary report, I mention all of this in the recommendations to the healthcare entity so that they do just that they definitely check with their clients. This is, I already talked about that the OIG is looking at these billings of these nurse practitioners. And here's the other area that, comes out through discussions. And I say to the entity, and that's why I always advocate an attorney-client relationship. But I said, listen, we're on the prophylactic side. We're not Medicare, but treat us like a pseudo-Medicare. And let us see if you have vulnerabilities in your workflow process and what you're doing. The OIG noted its concerns with the potential for unqualified non-physicians performing Incident 2 services. And they're suspicious that services may be prone to overutilization. Well, we had a note that the nurse did the entire note. Well, there's scribe rules if you're going to use a nurse versus a qualified nurse practitioner or PA or certified nurse midwife. The overutilization, when we trended that utilization and we trended problems, I think that what practice realizes with a staffing shortage, and this applies to Medicare. In order to do a shared split or an Incident 2, the assumption is that that's an eligible provider. These people join the practice. They haven't gone through the credentialing process. They're being billed under the doctor, and they're applying this concept of Incident 2 shared split, and they have issues of billing under another doctor or billing, et cetera. So that's the other area, aside from the pure coding, is the misapplication of these advanced practitioners and not realizing that they can't apply these rules, particularly with Medicare payers, if that payer is not credentialed with Medicare. They have to be an eligible payer. And, I hear, well, the third-party payers don't credential them. Okay. Well, we say to them, have your organization or work with your attorneys to review your managed care contract. you can't just assume that just because they don't credential them that your managed care contract doesn't have a clause that says no delegation of physician services to non-physicians. We see that sometimes. And we say, just because they don't credential them, because it's too expensive they don't credential them, doesn't mean that you don't have the responsibility to say, hey, we have advanced practitioners. How do we disclose it on the claim form? Do you follow Medicare's incident to, or do you follow state law? And you get an addendum to your managed care contract. So that's the due diligence that these entities need to do, and that, we say, I've worked with many attorneys who have done this managed care contract review and had made sure that they're in compliance with utilization of these advanced practitioners this way.
Now, Mary, I do have a question that's kind of appropriate, I guess, if I ask this one now. And this question comes from Judy, and her question is the medical coding being audited by machine or human eye during the evaluation or management process of fraud and abuse of billing? So how is the auditing being done?
The auditing, the auditing is being done by us, like auditors, human people. It's not like, you're saying that the people use like an auditing tool when we audit. And that's, there are audit tools that can help you with the history and the exam, but medical decision-making and plan of care requires, it's just that it's a tool. It requires our cognitive, clinical coding application to ensure that the documentation meets the evaluation and management guidelines. So we never use, there's never like a tool that's not driven by human intervention without that cognitive knowledge of coding rules and regulations to either override the machine, because we found out that some of these coding machines, their coding logic will drive it on a history and exam without taking into consideration that medical decision-making is the driver and the overarching criteria. And there are times we find errors in the machines, and we report it back to the entity. So it is so it's definitely not pure machine without human intervention. I don't know if that helps.
It does. Thank you.
Okay.
Okay, then you can continue on with the presentation. And we will be taking a break shortly again for some other questions. Thank you, Mary.
Thank you. So moving on to some other compliance risk areas on slide 16, the OIG in the March 26th report, and as you can tell, you can Google the OIG, the Special Fraud Alerts, and that web link. It gives valuable information. They focused their attention, and their alert was once again on potential client risks emanating from provider, physician, pharma, device manufacturer relationships. So, as these strategic associations become more prevalent and complex, that's where there is an increased need, aside from the nuts and bolts of the coding compliance, where I try to give you insight, evaluation and management, certain modifiers, the use of these advanced practitioners. Now we say to our clients, you need to have your attorney review your relationships each year. Are you in compliance with STAR clause and other anti-kickback statutes, the Sunshine Act provisions, high-tech HIPAA privacy regulations? And I see some attorneys come in with just a series of, they call their legal audit questionnaire, and they'll say, what's new this year? What have you done? Oh, there's nothing new, but, oh, you forgot, I just bought a financial interest in this recent surgery center. So it's these kind of things that, physicians innocently may not be current on these changes. So we always say that that's the other compliance area that needs to be taken into consideration. So when you work with your clients. The next slide, is, what are some of the steps to consider? We say, help your clients review their organizational relationships, to see whether or not they are current. Sometimes they're like 4 years ago, assess all the services they perform, consider the fair market value principle, document the relationship parameters in a written agreement, focus on strategic partnerships and alignments with, physicians. They do different things to improve patient care and reduce costs, and, they, find out that they have a different relationship with that primary care down the road, and they have a nurse practitioner that comes in one day a week, and they have different satellite sites, and that while it makes great business sense, they don't have the right employment relationship with the nurse practitioner. They're not employed under their group. They're not credentialed under their group, for Medicare. State law requires certain supervisory requirements for these satellite sites. And then I don't need to tell you what the problem was if they're specialists with this constant working relationship with the internal medicine to make sure there are not any violations with the Anti-Kickback. So again, a lot of times it's that probing question, isolating, and you'll find out that these are the things that just come out in discussion. So that's the key thing. That's important. On the next slide, which is slide 19, okay, so the question becomes, okay, how can I keep my hands around all this, and how am I going to be able to do that? And really, how can I really do this once a year? I only have an hour. They don't want to pay for me. I'm a high-priced attorney, and I'm just take it with a sense of humor, but that's what I hear, okay? So we say, okay, that's why if you work, I'm appealing to all of you to work together, and I'm not saying it has to be me, but find a coding consulting firm that you're comfortable in your state, your area, wherever, but you work in tandem to implement a compliance program. And we say the program is not this manual. It's just a series of activities. It can be auditing and monitoring, like we talked about. It's just simple, good business sense in today's healthcare environment. And, the compliance program is just a comprehensive strategy to ensure an organization consistently complies with applicable laws related to their business activities. Some of you are very familiar with your specialties, whether you're working with radiologists, the diagnostic equipment, etc. And they need to conduct internal and external audits. Now, the OIG doesn't suggest a physician practice implement a full-scale compliance program, which are the 7 elements that we need. The OIG in the small physician practice basically emphasize a step-by-step approach, which is what we advocate, not so much maybe for the same reasons that the OIG is doing, but we say do a voluntary compliance program, do a step-by-step. When we work with the attorneys and we understand the environment of the practice and your client, okay, because the OIG is in recognition of financial and staffing resource constraints faced by physician practices. But we say to the attorneys, if you do that staged approach, because of their resources, if you really do a staged approach and they're realistic on what they can chew off, like I said, you just do E&M one quarter, or maybe you do, you have an issue that surfaces, and maybe it is the surgical and the tail end of the year. From a learning and education, the staged approach allows for better saturation. And then once they see the value and the change and you follow up, they're more apt to say, oh, I found out that, maybe I lost money, or, we had the time to follow through just on this one issue. And we try to become extenders to the internal auditors and coders. So we like the staged approach and not a full comprehensive, because it's realistic on what they can chew in terms of business activities. So I almost hate the word compliance program. I always like to say ongoing compliance initiatives or activities, because the word compliance program puts a wall up, we find when we talk. So we just said, so we always advocate a nuts and bolts pragmatic approach. So with that, I believe we're ready for questions. So I'm going to turn it over to TASA to see if there's any questions.
We do, Mary. We do have a few questions. The first question I have is, are there any recommendations for specific training for the billing of services? And are the physicians trained or his office staff?
That's a great question. Yes, there are many areas on where the education, and I have some information later on in my materials. But Medicare offers free webinars. So our Coding Academy offers classes and webinars. The Physician Specialty Society offers education. And when people say, is it just the billing and the physician, at the minimum, the coding competency and the billing competency of the staff needs to be assessed. But we always advocate having a physician leader in the group attend the class, because that's where it's important to bridge the gap between the physician and the coder in understanding the clinical practice. And not all the billers have a clinical background, and it's important for the physician to understand it, because he or she can then go back to their other colleagues and say, this is what we need to document in our operative report or our note, and they can speak the same language. So it is a teaming effect.
Okay, thank you. That's really important information. Here's another question. Are the new compliance or are there compliance regulations for these new mini clinics that we're seeing pop up now? Are they bound under the same regulations?
That is a good question, because we're seeing a lot of these urgent care clinics, these mini clinics. The general rule is, if you're billing Medicare on a CMS 1500 form and you're collecting money from an insurance company or Medicare, you're bound by the rule. If it's a cash business, then it's a different area in terms of patient relations and other issues that the attorneys can deal with. But if you're turning in that claim form and you're collecting money from Medicare or Medicaid, then the answer is yes.
Okay, thank you. And I will now ask all of our attendees to enter the passcode word for today. So if you could, everyone, please type that into the chat section of the on your screen, and then we can have everyone register for their credits. And then one final question for this section that I have, Mary, and that is there a specific physician practice area where you see the most errors when it comes to medical coding?
And it's exactly where Medicare and the OIG, and it's the evaluation and management service. And it's the higher levels of services, like coding and evaluation and management services in the offices have levels 1 through 5, with 4 and 5 being the high levels. If you're 5, chances are they may be also sending you to the emergency room. So it's these higher levels of services. And that is why Medicare and the RAC audits are looking at that, or those areas, because it's the low-hanging fruit. It's the bread and butter. It's what internists, specialists do. It's the visits. You go to a doctor, and that little piece of paper they give you and says, bring this up to the front desk, that code they selected is the evaluation and management code. So it is the beating heart. It's the basic of every practice. And that's why we say, if you're going to start somewhere, start with your evaluation and management services.
Okay. That's really interesting, because I always get that little piece of paper and I never really know what that's for.
Yes, they have a series of codes if you're a new or established patient, and those are the evaluation and management codes.
Okay. All right, that's it for our questions for this segment, and everyone is typing in their passcode, which is great. And then we'll return the presentation and continue on. Thank you, Mary.
Thank you. So moving on to slide 21, if you're going to do some sort of compliance effort, call it compliance initiative, and I'm going to appeal to you to say what are your compliance activities. You need to have some sort of compliance pulse taking, and not use the word program because it really puts up a wall. In the 18 years, 19 years now that I've done this working with physicians. And really, compliance efforts must be practical, as we talked about. We know about the financial and staffing constraints. You're not going to achieve 100%. And basically, it should be defined in the positive light. We always say to the compliance officer, you're not the warden. You're there to say to the doctor, we're here to help you. You want to create that esprit de corps. Like I say to the doctors, we're on your side. We're the prophylactic exercise with the attorney here. So talk to us. Let us find it or help you correct it before Medicare comes. Because these RAC audits, CERT audits, Medicare, they will come. It's not a matter of if, it's a matter of when. So, like I said, invariably when we look at these thread of coding and billing activities, we find out that there's actually operational efficiencies and revenues we find. With these EMRs, we're finding a lot of these missed procedures and ancillaries going on. So it's not just upcoding, it is, the upcoding is the issue where you're dealing with the refund, area with the attorneys, but, we do find downcoding, okay? So, according to the OIG, okay, and their general compliance program for individual and small group practices, this was released in October of 2000, they said, there's an effective one should be one that is designed to speed and optimize proper payments, after word proper, minimize billing mistakes, and reduce the chances that an audit will be conducted by CMS. And so avoid conflicts with self-referral and anti-kickback. So how do you do that? You pick the high-risk areas that I talked about. We have people that don't understand this modifier 25, and they put it on everything, and then they wonder why they're a high-volume utilizer, and they found out that they put it on a visit and an EKG. So that's the billing education, and so that's why we say, they're looking at these particular areas, so focus on that. So what we do is we say to our clients, you know what, I understand that you feel that you have the expertise to do the audits in-house. And we're not arguing with that. And you should, because you need more than a once-a-year audit or once every 2 years. And they may be doing quarterly audits. But we recommend an external audit, and we always recommend it that it's done under attorney-client. And we ask the attorneys to understand, the reason why we say external once a year, we're not going to replace the internal person, but, an objective audit is a crucial element that can help maximize medical billing and spare exposure. And, aside from the fact that that healthcare system maybe, gets busy and they really can't, maybe they just can't attend to the medical billing audit, or they really don't have that added level of expertise in identifying that. What do you mean that? What's wrong if one cardiologist did the interpretation, but I bill it under another doctor, another cardiologist in the group? We're still under the same group. So that independent objective audit brings out some of these other potential compliance issues in the whole charge capture process that sometimes the internal staff don't catch as they're working with it. And the other thing is, these people are employees of the entity. So that external audit adds that further attestation of an independent objective audit because, they want to get angry at us. They may not, we're here to tell them what they need to hear, not what they want to hear. And in time, they will realize that we're on their side to help them. But an employee, depending on the culture, how compliance was presented, may be afraid to do so for fear that he or she is going to get fired, or they're like, oh, I'm not going back and talking to Dr. Smith. I'm just going to get my head chewed off again. I'm not bothering. So, there is that benefit to do it once a year. And we are the adjunct or the extenders to the internal. We're not the replacement. And that's why we say we're only here once a year. We're only here, once every 2 years. So that's the case for the external audit because, like I said, we're immune to the conflicts of interest, okay? And, if there are pressures, there are times, we're not here to say, oh, you know what, we just got information that there's a layoff going on here, so I got to make sure that there's increased revenue. I'm not going to really reduce our billing because I don't want to get laid off. We just left that meeting. It's amazing what goes through people's heads. And like I said, not that people intentionally, inherently are dishonest, but you don't want to create the temptation. So that external audit with counsel is that further bulletproof to attest to the effective compliance program. And then as attorneys who are required to report, work in conjunction with the board of directors and the board governance can say, I can say beyond the shadow of a doubt, these coding and billing activities are sound. Is it 100%? As I said to you earlier, it's not attainable. That's why people use that internal goal of 80%, okay? And they tier that. So that's one of when they say that, I'm like, I'm not saying I got to be there every quarter. I'm not saying I have to be there that often. I'm not saying I have to do that comprehensive of an audit. But you know what? As the OIG recommended, 5 to 10 E&Ms per doctor. Put it in your budget. The Medical Group Management Association says it's a cost of doing business. Put 2% of your net revenues into your budget and budget for this activity. Because chances are your refund in the event you're going to get caught is going to be quite a bit greater than if you had done this to assess it. And then working with counsel, if the issues are minimal, they may say do it once every 2 years. But if not, then we got to continue it once a year. So it's that dialogue, like I said, be pragmatic. Show them that you're not here to just constantly do that. And that's why I like the stage approach, because it's not this perfunctory exercise with a report. So like I said, on slide 25, we recommend that risk-based approach because we know about the time constraints and we want to be, let it be, make it a sound business decision. We say to the internal people, use your reporting, do an evaluation and management bell curve study. If you don't have time and you want to do it, find out where all your denials are coming from by payer. Focus in on the type of services that are causing you the denials, because if you're getting denials, you raise an alarm to the payer. Look at the productivity reports. We always say Medicare is like the rattlesnake that announces themselves before they come. You go into their bulletins and their local coverage, they tell you, and the OIG, they tell you where they, say, we see big error rates in discharge day management. Well, you know what? Look to see if you have that problem. So let it be a rifle-focused, risk-based ad hoc approach to your audit. So that's, and if you feel you need to do it under attorney-client, then you do it. And if you want to do it internally and you don't want to have an external audit, definitely get your attorney involved. Provide that information of the quarterly audit when you meet with your attorneys quarterly, we always say, when they meet with you guys, because that will trigger you, I think I'm going to recommend an external audit. No, okay, you can deal with it. So that's the important dialogue. And you'll see that, as I said, with the other payers utilizing the risk-based approach, I just gave you the link for the OIG strategic plan for calendar year 2014 to 2018, so you can see the activities that they're going to look at, and you can see if any of it applies to your clients. The OIG work plan was released just last week. So if you go into the OIG website, you can see it. I gave you the link for the report. As attorneys, I would say use that as your resource because that'll tell you what you need to advise your clients, and you will help us. Like I said, in addition to looking to the OIG work plan and the alerts, there are issues that are very common to specialties. What's really important, there's when you work with the specialties, the payers have their own bulletin, And what's different is today that, there was a time, and I'm dating myself, that the payers had these bulletins and the office managers had to go through to see what the coding and billing staff, what applied to them, and they had to sign it. Well, everything is online. Well, if you're so busy, out of sight, out of mind, you're not looking at these bulletins online. And it's there, but who has the time because it's online? So, a lot of the specialty societies announce things that they know are happening with their other colleagues. So these are things that the billing department needs to have their due diligence. And as attorneys, maybe you can communicate this to your clients in the coding billing. It doesn't have to involve us, but what happens is because you're the front line that helps us get in, once you communicate that, if there's an issue, they're going to come back and tell you, and you're going to know the difference. I need an external audit, or no, we can handle it ourselves. So again, I see us as, strategic partners, and we all work together when we need it, not as a one solution fits all. And what I ask attorneys is to ask the question: have you had an external audit? Is there what are some of the may I see the internal audit or the external audit findings? What's the report? Because I appeal to you on that area, because I can't tell you how many times I've worked with health systems that use their internal general counsel, and the same repetitive issues appear in my recommendations for 3 years in a row. So it's really important that if they're going to involve an external counsel as part of the board of directors and governance, that you definitely look at any documentation and find any repetitive pattern and find out why they're not addressing that, because that compromises the integrity of the compliance program. And that's where you can prioritize these issues. You can say, well, let's deal with these Stark issues. Let's deal with this relationship here. Let's talk about your new surgery center. Well, you know what? It seems that you have issues on evaluation and management. We find out you have issues on your imaging and your x-ray. And that's where you prioritize and you have them come up with a game plan. And that's what you'll find out, that internal auditor may be perfunctory doing an E&M or what I say is evaluation and management audit every quarter, but I'm like, switch it out. It doesn't have to be this rote E&M every quarter. It may be, well, this quarter we're doing E&M, next quarter I got to look at denials. And what I find is they've got into this habit of doing the same type of internal audit that became part of their routine job, and they haven't customized it to the findings of their unique situation each year. And that's what, I appeal to all of you as you work with your clients to make sure that their internal audits are not this routine, rote, perfunctory evaluation and management audits only, and then post-audit education, that they're looking at specific things. Compare, do practical monitoring efforts, whether it's same specialty peers. There's a lot of data out there where people can measure how your cardiologist compares to the, other cardiologists, and then that's the E&M bell curve. But create a schedule that says, well, this is what we found. Let's tackle these issues. Now, if you find out that you have a unique situation that just hit you in the midst of that quarter, you may have a resource issue, and instead of the external audit for the full compliance, we have attorneys that call us to handle that external audit on just that ad hoc issue because they don't have the resource or the expertise to handle it. And then we may never hear from that client for 5 years. But the point is, know when you need to just address it and be realistic with the resources, but definitely make it a pragmatic audit, and that's the thing that makes it more realistic. And you know what? We said, hey, find out, put up your warning indicators, okay? Yeah, when we hear practices that say, well, we haven't got any letters from RAC, we said, well, have you gotten any letter that has the word like program integrity on it? Oh yeah, we send them all our records. So a lot of times they don't even realize that they're sending audits out without discussing it with an attorney, because they don't realize by not letting you guys know as attorneys whether or not they're getting hit with these RAC audits. They don't understand the full rights and obligations in regards to these RAC audits, and that's where they really need to work with attorneys. And I just say you need to talk to your attorney because it's that asset test and running it by you that helps them hopefully avoid any further regulatory and compliance problems. But again, my advocate on the risk basis, not that routine just E&M. Look at what are some of the correspondence you're getting from the payers. Are there any high volume or unusual charges? What are some of if there's a constant code? We found a slew of these nurse visits, and we found out that they were incorrectly. It was a low-paying code. But it was an overutilizer, and here they didn't understand the correct application of billing nurse visits with 2-minute checks. So these are things that again, it's a constant educate. It's communication. It's letting them know they're not going to lose their job because they didn't catch it. This is what we do day in, day out. We try to say to the board of directors and the people. The organizational leaders, you can't beat up on your staff because they're dealing with so many different things, and their level of oversight is not at the level at what we can because this is all we do day in and day out. So we try to help the internal staff to say, hey, they've done a great job. Here are some of the issues. And again, we try to create that esprit de corps. And for the most part, a lot of the organizational leaders are great. They really understand that, and we don't see that typically as an issue. But with a question with education, as a certified professional coder, we're required to have education just to hold on to our CEUs, just like you guys do as attorneys. But either they have they can schedule an on-site seminar. We do that. Many firms do that. They can go to their own specialty society. There's newsletters. Like I said, Medicare offers a lot of webinars. Each Medicare state has their own local fiscal intermediary. In Pennsylvania, it's Novitas Solutions. So, Medicare says you can't say that you didn't know. So, and as you know, the definition of healthcare fraud has changed to known or should have known. So you have a responsibility to know what you don't know. Okay? Make sure that there is that documentation of that education. So with that, I'm going to turn it over to TASA for questions, and I appreciate your time listening to me today.
Thank you, Mary. And we do have a couple of questions for you. The next question actually comes from Jim, and he would like to know, when comparing external audit and internal audit results, how often do you see a difference in the results of those two audits when they stand side by side?
That's a great question. We definitely see that's the issue with coding because there is that level of subjectivity, and some attorneys say depending on the type of audit findings, if there's a one-level change on the evaluation and management, they're going to chalk it up to coder subjectivity. If there's a 2-level change, something that was billed as a level 4 and we're saying it's a 2, those are the ones that you investigate and you issue a refund. We definitely find discrepancies, but it's not just in the coding. We'll pick up these ancillary tangential compliance issues like use of the extenders, teaching physician violations, billing for services under another provider, authorship issues on diagnostic studies. The internal audit, they may be fine on E&M, but when they do the office procedures and the diagnostic studies, they're not documenting those procedures. So the internal staff. If there's E&M discrepancies, we do find them. We work with the internal team, and we become the trainer. And we hear simple things like, well, this is the code that was used by this other health system, and this is what we, were told to use. So, and it's not a criticism of the internal staff, but like I said, this is what we do day in and day out, so we're able to spend more time delving into the depth of it. So we do find the variations, and it does get resolved.
Okay, and here's the next question. How can we as attorneys help our physician clients with Medicare and third-party payer audits?
Well, you know what? The best thing that I can really appeal to the attorneys, because we need your help, is to really really help them look at their contracts, look at their relationships, look at look at what the RAC audits are doing, okay? Look what the third-party payers are doing, and really highly recommend either an external audit or review their internal audit and see if they've made changes to the findings of an internal audit. So, as I said earlier, sometimes the internal staff, they may say something and it falls on deaf ears, or they're afraid to do it because they're afraid that they're going to get fired. So really, we say look at some of these billing issues, medical necessity issues, look to see what the internal staff has done, and see if this is the same thing that has been done in the last 3 quarters, the last 2 years. And so that could be the trigger point so that you can help your clients with Medicare and third-party audits.
Okay, I think that is it for our questions. We're a little bit after 3 o'clock now, so I think we're going to just kind of close our presentation. I do want to remind all of our attendees that this webinar is eligible for CLE credit in California, Illinois, Minnesota, Missouri, Pennsylvania, and New Jersey. To ensure that you do receive your credit, please complete the survey at the end of the presentation. And again, some states do require that. I do also want to take this opportunity to thank Mary for her time and the effort that she put into this presentation. And I do want to thank our attendees for their time today. And I do want to remind everyone that in addition to providing testifying and consulting experts, TASA does also offer e-discovery and document management solutions. We also do have research reports, so if any of our attorneys are in need of reports on expert witnesses, we do have 3 different reports that we can offer to you. Again, thank you today for your attendance. Thank you, Mary, for the effort in creating this presentation. If you'd like to speak with yes, and I think that this actually was very an informative presentation, and it's a topic that is really coming to light today, in today's world. So that will close our presentation for today, and thank you all very much.